Okay, yeah, I can get started. All right. First off, I wanted to thank everyone for the opportunity to present today or the invitation to present today. I'm Tyler Richards. I'm a neuroradiologist at the University of Utah, and I'm going to talk about AI and neuroradiology. I will mention some commercial companies, but I have no financial relationships with any of them. So just a quick overview. I'm going to talk about kind of the current landscape of AI, especially AI FDA approvals as a whole, but really focusing in on neuroradiology. I'm going to talk about the key needs for making a really strong, robust algorithm, examples of when those key needs or features are missing, and kind of what those type of errors it results in. And then I'll talk about new developments for the future, the radiologist's role in those new developments, how these new developments can address some of the shortcomings in the past, and then briefly touch on foundation models if we have time. So I'm sure all of you have heard much about AI and AI models in radiology and used many of those models, but it seems like it keeps producing exponentially in terms of information out there. So sometimes it can feel like drinking from a fire hose. If you go to RSNA, there's a huge exhibit for the AI showcase, and there it's extremely overwhelming. Everyone wants to talk to you and tell you about the great sensitivities, specificities, and accuracies of the AI models that they've come up with. And it can feel very overwhelming to sort through all that information. So the ACR has a great resource called AI Central, which summarizes the FDA approvals that are currently out there for AI and radiology. Here you can see over time on the bottom left that those FDA approvals, as you would expect, have increased over time. They have interesting hit somewhat of a plateau in the last few years, but this year is obviously not complete, so I expect it to go up a little bit. But it is starting to, the curve is starting to plateau off a bit. Specifically in by subspecialty, neuroradiology is the highest producer of FDA approved models at around 30%. And then specifically, you can break down this further within each subspecialty, and you can see by modality. Most of the neuroradiology models are CT based, and then about half that number is MR based, with a smattering of a couple others here. In the bottom right, this is a QR code to this website if you'd like to explore it a bit further. So you can further break down even within neuroradiology what those AI models are focused on. Kind of the top two are a mixed bag of AI models that don't fit into a great specific use case. But a lot of the brain anatomy models are things like NeuroQuant, which looks at volumetric analysis of different parts of the brain and helps you predict different dementias and things like that. You will notice though that a lot of these models are focused on both ischemic and hemorrhagic stroke, make up a very large portion of the FDA approved models for neuroradiology, and also fracture detection and aneurysm detection are other common ones. You can see over time that neuroradiology did actually peak in 2023 for FDA approvals for AI models, and it actually dropped a bit in the last couple of years. Also on this website, you can see AI model cards, which give a nice summary of each AI model that's been FDA approved, the type of FDA approval it achieved, and then also what the expected output and use case for each of those models are. Very importantly, it also breaks down on the training data set and what was used to train those AI models. But what you'll find at the current state is that these AI companies are not required to actually state like the race and ethnicity and age breakdown of these AI models. So a lot of the demographics of these AI models that go in the training set are not available. And I think that's something as a whole that us as radiologists in our society should push for, because you can get potential biases that aren't recognized based on not having this information. So this one did give an example. This was one of the few that actually showed a outside study that looked at their model and tested it, and it did have the race breakdown in the paper that evaluated this AI model. So kind of the big groups of some of the successful AI models currently in neuroradiology are for triage and detection of emergent findings. This makes up a lot of these stroke and intracranial hemorrhage detection models. Most of those are object detection, kind of identifying the area of using computer vision to identify the location of the object it's detecting the pathology. Also, there's a lot on diagnosis and grading. Many of those are classification models. Quantification is another frequent topic. Like I mentioned, a lot of the dementia evaluation, volumetric segmentation models are in the quantification space. Treatment prediction is one that's mainly limited to the research realm at this point, but that's kind of like the holy grail of AI and neuroradiology, in my opinion, being able to predict which treatment would be best for patients with gliomas or metastatic lesions in the brain, or even other things, which I'll get into in a bit. Image enhancement is probably one of the most wildly successful AI use cases in radiology as a whole. I think a lot of sites are using image enhancement to scan the patients faster, especially on MRI, and being able to have shorter acquisitions, but similar quality diagnostic images to look at. Next, text generation. That's also been a more recent, over the last couple of years, hot topic for report generation using LLMs. So as I mentioned, the triage and detection is one of the more common type of AI models that's used in neuroradiology. Here on the left, you can see intracranial hemorrhage detection, which is a common one. There's many FDA-approved models for that. This is showing a saliency map, helping you identify the location of where it's detecting that small, likely subdural hemorrhage there. LVO detection is another one. So large vessel occlusion detection. Here you can see it's localizing the LVO to the left MCA here. This model also actually looks at collateral evaluation to predict how bad the stroke is going to be. And then, I'm not sure why that happened. And then here on the right, you have cervical spine fracture detection, which is another common AI model that's out there, both in research and FDA-approved forms. So one of the research use cases I found too was using AI to detect focal cortical dysplasia in patients. And again, this is a localization model showing you where it detects those FCDs. And these type of models are great because it's easy for the radiologist to supervise them and kind of see where the model's detecting that abnormality, and then you can visually inspect and see if you agree with that interpretation. Some of the newer FDA approvals have been focused on using non-contrast head CT to detect the likelihood of large vessel occlusion. And so that represents a good understanding of kind of the clinical workflow and how things work. So if a patient comes in and they just have some non-specific neurologic signs and get a non-contrast head CT, if the model is able to flag those quickly, it's potential that you could actually go ahead and just get the CTA right after the model flags it if the radiology is able to review that very quickly, rather than having the patient leave the CT scanner room. Another more recent published FDA models are for ARIA detection, so amyloid-related imaging abnormalities in patients on anti-Alzheimer medications like lecanemab. So a lot of these can detect small sulcal effusions, which you can see here, parenchymal edema, small microhemorrhages, and siderosis. So those are all important to detect in these patients. Next, the next category, diagnosis and grading. There's been a fair amount of research done to predict molecular markers in gliomas. However, they have pretty limited sensitivity and specificity. So here's an example of a model that was created to predict EGFR amplification and MGMT methylation, which are both really important molecular markers for treatment and prognosis in these patients. So another classification model that's been a common target is for evaluating degenerative changes, especially in the lumbar spine. So categorizing the patient as mild, moderate, or severe, spinal canal stenosis, neuroforaminal narrowing, and subarticular narrowing. This represents a great use case because it's something that can be very tedious to the radiologist, and is also something that doesn't have the greatest inter-reader reliability. So having a more standardized approach can be helpful for the care of these patients. And then quantification, as I mentioned before, things like evaluating normal brain structures and how they compare to others. And dementia is a common one. Another common one is presented here, where MS plaques are quantified to monitor disease therapy in these patients over time, detect new plaques, and also in some cases detect enhancing plaques. Quantification can also be helpful in intracranial hemorrhage evaluation. So if it's a patient that is undergoing serial scanning of their intracranial hemorrhage, being able to detect small changes in volume in those intracranial hemorrhage can be very difficult to do visually. But if it's segmented and the volume is quantified, that can be helpful for interpretation. And then finally, another example of kind of doing a lot of work that can be tedious and have low inter-rater reliability is looking at Cobb angles and measuring the curvature of the spine in patients with scoliosis. This was a great paper here that many of the prior measurement algorithms had been on patients without surgical hardware, but this actually looked at patients with some of which had extensive surgical hardware and was still able to accurately measure Cobb angles in these patients. As I mentioned before, kind of the holy grail is treatment prediction in AI models. However, a lot of these are kind of black box in their approach. So there needs to be big studies to evaluate these to prove that they're reliable over time and don't have a lot of biases cooked into them. So this was actually an interesting one that looked at transforaminal epidural steroid injection and was able to predict how well the patient's or how much improvement in the patient's pain score would happen after epidural injection. Again, not going to talk too much about image enhancement because it's such a big topic, but here on the right, you can see is a normal acquisition of 2 minutes and 5 seconds at our institution. And then here on the left is the image enhanced deep resolve by deep resolve T1 post contrast, which you can see there's actually arguably less noise in this reformatted image that's at 53 seconds compared to 2 minutes and 5 seconds for the traditional acquisition. So, like I mentioned before, at RSNA, you're approached by all these different vendors that have these excellent accuracies, specificities, sensitivities reported for their AI algorithms. But it's very difficult to just compare those numbers because their test sets are very different. And so, one idea that you could have is like a bake-off or benchmarking data set to evaluate all these AI models for especially common use cases like intracranial hemorrhage, for example. So I think that's a good role for potentially some of the larger radiology societies or even the federal government as a whole is to come up with these expertly annotated data sets and then compare the performance between these different AI models to really get a good sense of how they compare to each other in performance. So this is a pretty well-known quote, but this is by Jeffrey Hinton, who is a pioneer in AI research from the technical side of things. But part of the quote said, people should just stop training radiologists now. It's completely obvious that in 5 years, deep learning is going to be better than radiologists. You can see he made that quote in 2016. So didn't really completely pan out. So, a recent paper actually showed that there's more vacant radiology positions that exist than graduating radiology trainees. So, it's actually quite the opposite. We need to be training more radiology trainees based on this paper. So why was he so wrong? There's a lot of factors that go into that, but part of the issue is that he just underestimated the complexity of radiology. At this point, everyone kind of thinks that they can Google some things and is an expert in a different field that they're not truly an expert in. So here's just some examples of things that are really tough for AI models to evaluate. This is an example of architectural distortion in mammography. And then AI does have large data sets can kind of overcome this, but AI has trouble with artifacts, well-known artifacts to us. Like, for example, here's a CSF flow artifact that can cause issues in AI models. So the main elements that make up a robust deep learning algorithm development pathway, something that's very clinical useful, requires all these factors. I'm going to go through each of them and give an example of each. So I'm not going to read them just yet. But what kind of happens, or one of the big limiting factors too, is that there's a division of resources here. So on the top left, we have industry that has lots of money to invest, lots of programmers, and lots of very powerful compute servers to use. So they're great at kind of the bottom three that I mentioned before, the architectures, developers, compute. They have streamlined deployment, or and they're capable of coming up with streamlined deployment, and also can develop software for transparency and quality control. Whereas on the other hand, the academic side of things, we have the expertise to identify the high impact use cases, understand the clinical use and clinical workflow. We have the large data sets and the patient data that's available to us, and we as radiologists can be the high quality annotators. So there's oftentimes separation between these two resources that make it difficult to develop really great AI algorithms. So identifying a high impact use case is one of the key roles of the radiologist. It's often the first step, and the radiologist kind of identifies a key use case and then decides to make an AI model based on that. So historically in neuroradiology, as I mentioned before, it's been stroke or focused on ischemic and hemorrhagic stroke and oftentimes fracture. Typically, it's focused on diseases that have high prevalence and high impact. Other high impact use cases, more so in the research realm, are early detection for diseases that can be treated better if they're detected early, like Alzheimer's disease, and then also radiologist blind spots. So, for example, being an academic neuroradiologist, I feel pretty comfortable with a lot of evaluating the neuroradiology parts of the scan, but different body parts like the chest, abdomen, pelvis are often included in the field of view. So AI algorithms that evaluate those are more helpful to me. So understanding the clinical use. So this is a great example of where that failed. So I'm picking on this is Rapid AI. Rapid AI has probably been one of the most influential AI models in the commercial space out there on patient care, but they didn't completely understand a lot of the workflow, and it resulted in issue in their software that was published. So patients that recently got a dose of intravenous contrast, when they underwent CT perfusion, the rapid analysis was shown to underestimate the core infarct. So here you can see their output here showed there's a large ischemic penumbra in the right MCA territory, and it essentially calculated no core infarct here. But if you look at the non-contrast head CT, you can see there's a large area of loss of gray white differentiation in the right MCA territory. And they went ahead and got a MRI, and it showed this whole area was restricting on diffusion. So really this whole area looked like a core infarct on both non-contrast CT and MRI. So this was just not understanding clinical workflows. So many of us on this call probably work at tertiary stroke centers, and it's oftentimes the case where a patient is initially seen at a smaller non-stroke center hospital, and they get a CTA showing a large vessel occlusion, and then they're transferred to the tertiary stroke center where they undergo CT perfusion. So it's actually pretty common that patients get a dose of IV contrast before they actually get the CT perfusion at the stroke center, so that this error can actually come up pretty frequently in the kind of the clinical workflow for stroke patients. So another key feature is many of the commercial companies don't really understand that the overstimulation of radiologists by sending them too many alerts. So there's something called alert fatigue, that when the radiologist is just sent alerts after alert and they all don't pan out, eventually the radiologist just starts ignoring those alerts, and then the AI model's not helpful at all. Getting large, diverse data sets is definitely a big challenge in AI research. So there's barriers to sharing data, such as getting data use and data transfer agreements in place. This is potentially a big issue for industry. A lot of the public data sets that are available out there are for research purposes only. And so they oftentimes have to come up with collaborations or even buy data from different institutions to train their models. And then not having diverse data sets can have introduced bias into the model. And so this can be a big issue in models that function kind of as a black box, especially in treatment models. And when you don't know why the model is predicting a certain treatment, that can be a big issue if you don't have a very diverse data set. So high quality annotations, this can be very time consuming and very expensive. So buying radiologists time to annotate scans is very expensive for commercial companies. Here's an example of a glioma segmentation. You can imagine if you have to hand draw that to establish the ground truth, that can be very time consuming. And if you don't have high quality annotated data sets, it's kind of the old garbage in, garbage out. You're not going to get a good model if your starting data isn't high quality. And so going to the key point of having good architectures, developers, and compute. So this is something that's more present in industry and takes time for institutions to set up these resources, and they're still limited in the amount of money and programmers that they have. And then focusing on streamlined deployment. So this is again tough for institutions to develop the software to launch their AI models, especially if they're research models. But here's an example of a platform that in this study, they basically compared three different ways of notifying the radiologists about urgent findings. So in the middle here, you can see this is where they put a flag, but they didn't actually reprioritize the list. On the left, I believe this is showing a widget that when you clicked it, this screen opened, but a widget would pop up on the screen. And then on the right, there's a flag and also list reprioritization where you have this acute AI findings here. So they found that when they compared these three methods, actually these two here, the widget and the flag, didn't result in any faster interpretation of the flag scan, and only this list reprioritization actually changed the turnaround time, and it actually wasn't even that much of a reduction. It was about 3.5 minutes with list reprioritization. So even when you have a very streamlined, slick way of deploying an AI model, it still doesn't always result in a decreased interpretation time for urgent findings. Um, Next, looking at transparency and quality control. So, like I mentioned before, it's important to have explainable AI and not have just a black box situation. So if an AI model is using a lot of data that's hard to interpret and sending it through the model and then basically picking which treatment is the best, this creates a big issue, and clinicians aren't going to trust this unless there's extensive amount of data proving that the AI model is accurate. So coming back to Jeffrey Hinton's quote, he's since changed his quote and said that he now believes that medical image interpretation will be performed by a combination of AI and a radiologist, and will make radiologists a lot more efficient in addition to improving accuracy. So I think this is a lot more along the lines of what us as radiologists believe about AI's role. So touching briefly on this, some ways that people have tried to circumvent some of these challenges is uh, covering a lot of these bases about large, diverse data sets with great annotations is some of these multi-institution initiatives to make large data sets have been undertaken by MIDRIC and the Cancer Imaging Archives. And then radiology AI has data resources available too for some of these large data sets that can be used. A lot of these data sets, though, are limited to research only, so they're not available to commercial entities. And then Bunker Hill is a company that has a consortium of different institutions that can share data under a blanket data use agreement and develop AI models based on that. So that's another way is having a consortium that can share data. Um, the RSNA AI challenges have been a great source for data, and also the developers come and compete in these challenges and produce really great models that way. It still leaves you with not a great way to deploy these models, but it gives you great data sets to train models on, or even models themselves that have won the challenge that you can use and deploy with some work of coming up with a way to deploy that at your institution. Another way around the data transfer agreements is using federated learning, where essentially the model goes to different sites and the data doesn't leave those sites, but the model is updated and trained at each individual site. This is more technically challenging, but at least it doesn't require all the data use agreements to be in place because the data is not actually leaving the different hospitals. So the FETS Post Challenge is an example of federated learning where each of the sites participates and gives data for brain tumor segmentations, and the model is trained, and it's resulted in really great results based on using federated learning. So I'm going to try to wrap up here, but one of the things that I think needs to happen is that some of these barriers between industry and academics need to come down, and industry needs to sponsor and work with institutions to create these models, and institutions need to find a way to open up to share data, their valuable data and expertise with commercial developers in order to make really great commercial models. So finally, I'm just going to briefly mention foundation models. This foundation models basically work by ignoring a lot of these other critical aspects for making a strong model and just have really large, diverse data sets and really powerful compute to kind of overcome some of these other challenges. And so I'm not going to get into the definitions, but you can see foundation models are obviously blowing up. They've been last year in radiology AI, 5 of the top 10 most cited papers were on LLMs and their applications in radiology. And then on top of that, some of them have been used in neuroradiology or beginning to be used in neuroradiology. For example, people are using CT or training CT head foundation models. And so what they do for foundation models, it covers both large language models and vision language models, like we see LLMs like ChatGPT and others. So vision language models just use both images and text pairs to train a model that can be used for many different purposes, like GPT. And so in the CT head foundation model, they were actually using it to, sorry, go back. They were actually inputting, they had a database of somewhere around, I think it was like 90,000 text and image pairs for these CT head models, which actually isn't even that large. But they were able to input CT heads and come up with an automated report generation that it wasn't great, but it does kind of show you where the future is headed, that this was able to come up with these radiology reports just from the images, and about 74% of them were indistinguishable from human written ground truth. So it's definitely the accuracy needs to improve a lot with these, but you can definitely see where a lot of these foundation models are headed. This was a more recently published foundation model, which had 360,000 non-contrast head CTs. So you can see that the databases or these foundation models are getting bigger in terms of the data sets that they're using. So that's where I'm going to leave off. Does anyone have any questions, or we can just head, or you can take over, Jordan. And here's a slide. If you want to learn more about foundation models, these are some great resources that you can look into to learn more about those.
Oh, that was really fantastic, Dr. Richards. Thank you so much.